Well, the good news is a bunch of my first slides have already been covered, so we can jump through this. I would just like to add a few of personal pearls around acute Lyme. One is that you can recognize those who are complicated, who need potentially more antibiotics or longer antibiotics with a couple things. One of them is neck pain. So once there is significant neck pain, they've had a EM rash potentially, or pull the tick off them, and neck pain would actually be the time when spirochetes are transiting and you're getting blood-brain barrier and you're getting some low-grade meningitis. This is a bad sign that central nervous system symptoms are not far behind, and usually they go on to progress to headaches and brain fog and everything else that's bad. Those folks need potentially more antibiotics and longer antibiotics. Also, those with multiple EM rashes, like Elliot's case. I'm a bit of a gunslinger because I've worked for 15 years seeing chronically ill patients who are completely discombobulated and disabled. So I want to prevent that as much as possible. So I would actually give those kinds of patients potentially, in addition to a doxycycline or minocycline, azithromycin as a double coverage. We are finding increasing rates of resistant Borrelia as well, resistant to doxycycline. And potentially stretch that out from 3 weeks to 1 to 2 months, depending on symptoms. The other thing is somebody who asked about recurring antibiotic exposures. For patients, I have one fellow who is a horse rancher outside of Kingston. He's literally picking ticks off his horses and himself on a daily basis. He said, well, you pick and choose. Here's a prescription for doxycycline that he's got on his shelf for standby therapy. He said, okay, you've got a rash, then take it. And the last thing to be aware of, and I'm going to extend my talks here beyond Lyme to include the most important second thing to get from a tick that we haven't touched on, and that's babesiosis, a completely unsung serious infection. And if we think that the diagnostic tests available for Lyme are bad, they're nothing. I had, actually that guy in Kingston was one of the few that I've had positive Babesia serology from McGill. I've had, in ordering that test maybe 1,000 times, I've had 5 people positive for serology for babesiosis. But the acute presentation of Babesia is very much important to pick up on. You don't want to miss it. They are basically like North Americans' version of malaria. So they're getting cyclic fevers potentially, or at least very high fever, very severe night sweats and day sweats, soaking the sheet sweats, and then respiratory symptoms that aren't really common with Lyme disease. So folks who are describing air hunger, gasping for breath, and they're not exercising, but they can't catch their breath. And of course, if they're acute, they may actually have hemolysis and low hemoglobin, low oxygens. Those are emergency. If they have high parasitemia loads of babesiosis, they actually may need additional in-hospital treatments. So, this you've seen, and we've touched on this earlier, and I don't really think it's worthwhile in this group to spend a lot of time explaining why we have this dichotomy of conventional practice and thinking inculcated by the Infectious Disease Society of America with their guidelines, and what would be considered the other end of that spectrum, ILADS, in terms of recognizing the possibility of chronic persistent infection. Personally, I think that the persistence of living spirochetes is quite likely the explanation, or one of the main explanations, or recrudescence, or perhaps for those in endemic areas getting recurrent infections of different strains, which of course is problematic because you don't have durable immunity, as Mulaney pointed out. I also think immune derangement and inflammatory sequelae and changes related to peptidoglycans, for example, which are known to be part of the pattern with post-COVID long haul, which, to be honest, when I look for Lyme in post-COVID long haulers, I find it frequently, probably 3/4 of the time. I do not think that the default should be psychiatric or somatoform diagnoses, which sadly is where most patients end up, in my experience. over these years, the typical pathway is they see their family doctor, they get a referral to neurologists, rheumatologists, internists, and eventually, after they see 8 or 10 of those, psychiatrists. I asked AI, can you find bacteria in latent syphilis? And the answer was absolutely yes. I asked the same question, which I'm not going to put up here, because for Lyme, it was very wishy-washy. It's like not a lot of studies showing they've looked for it, haven't find it, blah, blah. Why, since they're both spirochetes, would you not be able to find spirochetes in tissues? But the reality is we don't really know where they go. This, however, is the one diagnostic test nobody's talked about so far, but I find fascinating, is xenodiagnosis. Xenodiagnosis is raising ticks in a laboratory, knowing that they're sterile, and then allowing them to feed on people who may have post-treatment Lyme disease syndrome or chronic Lyme. So the first of these studies was done in 2014. Roughly 36 subjects with chronic symptoms were subjected. You got to wonder about the rationale of having your arm taped up with 20 or so larval ticks. But of course, what they do is allow them to feed on the individual for 4 to 5 days, then they take the tick and they grind it up and do PCR, much like Justin does. Okay, what did they find? Well, the majority of them did not have evidence of Lyme transmission into the ticks, but a few did, 3 of them. Most notably, one woman who had 3 years of antibiotics for chronic Lyme prior to undergoing this test, and then the ticks showed up with Lyme in them. So interesting that the ticks can find the Lyme, we just can't. How do they do that? That's interesting too, and Melanie probably knows more about this, but when a tick is biting, it has some signaling molecule that goes out into the systemic blood system and calling all spirochetes is basically a calling card to come and get into me. So one of the interesting therapeutics that is coming down the pipe, because they've been able to purify that signaling molecule, is to inject that into people to liberate and perhaps get stationary Lyme bacteria that are hiding in their dormant form to come out of hiding and become spirochetes again and float around your bloodstream, and then be much more sensitive to treatment. So I will say that the interest in xenodiagnostics as a clinical test are being repurposed by a recent trial that's still recruiting. Tufts University is doing this with NIAID, and hopefully we'll actually find what we think the answer to this is that indeed persistent spirochetal disease in the form of a dormant non-cell wall intracellular infection that's not replicating very rapidly. And by the way, what do most of our antibiotics do? They block the formation of a cell wall by the bacteria, and they prevent it from replicating. Well, if it doesn't have a cell wall and it's not replicating, regular antibiotics are not doing very much. We'll talk more about disulfiram and methylene blue and dapsone tomorrow. Sam Donta published this in January of 2022. It's worth a read. Basically, it's what we don't know about Lyme, and he's trying to bridge this divide between, if you will, IDSA and ILADS. So he talks just quickly here that the bacteria can be found in the initial rash, occasionally in the bloodstream. After 2 to 3 months, it's not known where they go. Diagnosis and treatment of early Lyme disease is straightforward, as Elliot mentioned, but the etiology of relapsing and persisting symptoms is yet to be defined and presents clinical challenges. No guff. There are no current tests to determine if the infection is still present or absent. So even if you have serologic positive testing for any infection, and we see this a lot, because I order Epstein-Barr virus, and like 3/4 of the population have it, okay? I think it's post-EBV, it's chronic EBV, doctor. I don't think so, but the reality is serologic positivity doesn't mean active infection. What active infection tests do we have? LE spots are really my go-to as well. We'll talk more about that. So what is the definition of chronic complex illness in the first place? Just to kind of lay the framework here for a discussion around chronic tick-borne illness, long duration. So typically 6 months is what's used as the defining criteria, and no spontaneous resolution. Although, as Elliot mentioned and others, this symptoms can wax and wane. They're typically not symptom-free in between. These are complex because they often involve multiple systems. And these systems are, of course, interconnected. Typically, no single cause is identified. A cumulative response to multiple factors is invoked. And after lunch, hopefully you'll be awake enough to get my perspective on functional medicine and sort of the idea that there isn't a silver bullet for people, but there might be silver buckshot. Sadly, again, our patients typically have fallen through the cracks of conventional medicine. They've had multiple specialist referrals and investigations, trials of treatments that haven't necessarily resolved the problem because the typical reductionist approach is, it's a bug, here's a drug, oh, it didn't work, I guess it's in your head. And then we label them with syndrome or syndromic titles that frankly don't reflect etiology. I have a lot of patients who are part of the ME/CFS Society, and that's great. But what is that? That doesn't actually give us the diagnosis or an etiology. I will say, if you look hard, the majority of folks who come in with fibromyalgia or myalgic encephalitis have Lyme disease. Post-treatment Lyme disease syndrome, SIRS, and we're going to talk along the way this weekend about the impact of mycotoxins and mold disease and the systemic inflammatory response system, but many people have that. And then, as I mentioned, post-COVID long haul. So I was grateful for Dr. Hawkins to mention this because I would really like every primary care doc and every emerge doc in our fair country to have this on their desk and use it, because it is the absolute best, cheapest diagnostic test that you can have. And I'll just point out, or I have to do it over here. This is the front page of the questionnaire. And I show this and hand this to patients routinely because it really resonates with them that they're having majority of these symptoms that are in the pink box here: fatigue, joint and muscle pains, tingling, numbness, burning sensations, stiff neck, headaches, light and sound sensitivity, dizziness, difficulty falling asleep or staying asleep, memory and concentration problems, chest pain with palpitations, psychiatric symptoms. And then over under the MSIDS box is mentioned some of the findings that we've touched on: abnormal liver functions, allergies, which typically suggests a shift of your immune pattern to a Th2, autonomic nervous system dysfunction, vagal nerve dysfunction. We see a lot of that. Endocrine abnormalities. Lyme is an endocrine disruptor. Environmental toxicities, et cetera, et cetera. I won't get into all of these details except to say you can make a diagnosis definitively in your office based on people having these many symptoms of these many systems. And I also appreciate Dr. Horowitz's approach to not calling this chronic Lyme disease, because it often isn't just chronic Lyme. It's multiple systemic infectious diseases all at the same time. Your immune system has gone on a hiatus potentially, and now your Epstein-Barr has reactivated. Your cytomegalovirus is reactivated. Your human herpes virus 6, HPV6, we find a lot. You may have, obviously, community-acquired mycoplasma or chlamydia that have become persistent. They may come out to play when you have a tick bite and get a bunch of infections, which, again, can be multiple. So this is the actual questionnaire that has been alluded to, but good to actually lay it out here in that there is a standard way to gather quantitative data for this. Just a few caveats about this particular questionnaire. If you do have it on your desk, great, but patients routinely give themselves five points under Section 2. Even if they have only one thing, you're supposed to have all of those. So he has cleverly weighted the classic presentation of Lyme with fatigue, cognitive dysfunction, short-term memory loss, forgetfulness, joint pain or swelling, and peripheral neuropathy, tingling, numbness, burning, stabbing sensations, and the sleep is a dramatic and primary change. I used to sleep fine, got Lyme, now I'm tired but wired. So you need a score of 3, i.e. severe, in each of those 5 domains to get an extra 5 points. The majority of our clients and patients actually come from a Lyme endemic area, so under Section 3, they should have a 2 points there at a minimum. Most of them have come in with other kinds of positive tests that get scored. There are mental and physical functioning scores. At the end of the day, what's at the bottom of this, much like Ralph Hawkins was mentioning, 21 to 45 merits further testing, and over 46 has a positive predictive value that's substantive in the high 80s. Dr. Horowitz republished that with a second validation study. Anything over 60s, people have a score of 60 or more, has a positive predictive value in the mid-90s. So again, a very useful screening test to have on your desk. There's the actual publication, empirical validation of his questionnaire. So moving into pattern recognition, and we've kind of alluded to this, but I will just like to point out some pearls here and some highlights. One of them is perhaps the most important, which surprises me that neurologists don't know this, or they do not appear to, is that migratory neuropathy, so polyneuropathy, this numbness, tingling, burning that comes and goes and moves around the body, there's only one thing in the world that causes that, that's Lyme disease. So that's a very positive diagnostic indicator. And patients will describe this in painful detail because it is horrible. They have formication. Gotta be careful how you say that word. They feel that ants are crawling on them or bugs. They have these sensations in the skin of things moving, of water droplets, and of course, dysesthesia, burning pain, tingling, and they, unlike multiple sclerosis, where if you get that, and you can, it comes and stays in one distribution typically. Doesn't come and go. Similarly, there are only 6 or 7 things in the literature that are causing migratory polymyalgia, polyarthralgia. So folks that describe muscle aching and joint aching, notwithstanding a bona fide monoarthritis, just having horrible aching pains. And this is perhaps the worst thing for people is just, they end up in chronic pain clinics. They're getting a lot of stuff for chronic pain, often opioids and other drugs. They're getting injections, and yet it comes and goes, it moves around. That is classic for Lyme, and again, very few other things do that. I agree that my clinic has been nicknamed the Brain Fog Clinic, as has Elliott's, because most of them have described dramatic changes in their cognitive function. And then they're fatigued. Many of them so much so that they describe, when I ask for quantitation from 0 to 100% compared to their baseline normal energy, said 10%, I can't get out of bed. We have many patients who arrive in wheelchairs because they can't get up and around. So this is the one I'd like to spend a bit of time on because I probably have 200 or 300 patients with babesiosis that I know of. Probably close to 2,000 now with Lyme, but this is something that is relatively easy to recognize clinically, not easy to diagnose laboratory-wise, but again, I think the cost-benefit analysis that Dr. Hawkins alluded to is favorable enough that it's worth a trial of treatment for people who have this cluster of classic symptoms from babesiosis. And now we're talking about chronic low-grade parasitemia. And obviously for those who are microbiology inclined. This is the classic form of a trophozoite of babesiosis, so-called Maltese cross. Can be seen in a blood smear, but rarely is. So, especially because these are often low-grade parasitemias, you'd have to look at thousands of high-power fields to be able to see one of these. But if you do this, it's obviously a positive diagnosis. So again, fevers and sweats, nighttime, especially nocturnal, daytime as well, drenching the sheets, having to change their bedclothes or the sheets, air hunger, severe headaches, more so than even with Lyme, weirdly a chest wall pain syndrome that often gets them off to see cardiologists with no diagnosis, and an acute onset of anxiety when they have this infection, and shortly thereafter, when folks have not had anxiety problems or mood or mental health issues, is another telling sign for this condition. They may also endorse oxygen changes. Many folks now are wearing Oura rings or eye watches or something else that tracks their O2 sats, and say, okay, well, I used to have an O2 sat of 98%, now it's 94. And this is actually because this is an intra-red cell parasite that's interfering with your ability to oxygenate and carry hemoglobin. So chronic Bartonella, we diagnose a lot clinically. I have been always puzzled by Justin's reports that it is not in the ticks in Ontario because everybody thinks it is. And it may be just because when I also ask them, do you have dogs and cats? Most of them do, one or the other or both. And so it may be that it's primarily animal transmission, but in the setting of carrying other infections, and with this immune dysregulation piece that we're talking about, it may be that Bartonella that you might have had contained and controlled when your immune system was working is no longer. Of course, it has got the name of cat scratch disease or cat scratch fever, Bartonella henselae in particular, partly because it produces a classic rash that looks linear, like a cat scratched you. I got to start doing that. There are some interesting other manifestations of Bartonella that are unique, one of which is it's one of the only tick-borne infections, perhaps other than tularemia, that produces lymphadenopathy. So people who come in and say, I got lymph nodes, especially in my neck or elsewhere, that are not coming and going, they're not reactive necessarily, and they onset after a sudden illness, this is something to think about. Obviously, these linear rashes that come and go in an evanescent every 2 or 3 days kind of pattern would be unique. Bartonella also has a vascular adherence preference and can cause angiomas, so you can get another rash that is kind of red dots. Weirdly, folks with chronic Bartonella describe excruciating pains in the soles of their feet, sometimes up into their ankles or shins, and feet pain is, again, a bit of a red flag for this. They also can be those folks with chronic persistent facial pain, dental pain. They are seeing dentists recurringly because they've got discomfort and nothing can be found. And then the other central nervous system feature of Bartonella to be aware of is manifestation of pseudoseizures or seizures. But often these folks have a kind of profound neurologic presentation that has escaped the diagnosis. They can end up on anticonvulsant medications, but that is a less effective treatment than antibiotics for them. We touched on this, but I'll just expand on it a little bit because we are seeing more of it. I have a few in my practice. One thing to be aware of is that most mammalian meat that we eat, red meat, has this alpha-1,3 galactose, except humans, we don't have it. And so it turns out that this particular antigen is in the saliva of the Lone Star tick, and you are developing allergy or potentially even anaphylaxis after meat ingestion because you've essentially developed antibodies to alpha-1,3-galactose. The other thing that we haven't touched on yet, but is part of MSIDS, and I would argue that is a very significant problem that is not being appreciated by many conventional practitioners. It seems to have landed squarely in complementary practitioners' practice. But I started out as a general internist, segued into starting in 2003, my first military patient, because I was in the military at that time, who from Kingston came with a long list of complaints. She was getting periodic antibiotics and felt terrific on those. And I made an impassioned pitch to the Surgeon General at the time in my capacity as the Surgeon General's Director of Internal Medicine for the military, that she needed to have a consultation with a Lyme specialist, and recommended Richard Horowitz. And his cost was, and still is, quite expensive for a second opinion. And the Surgeon General said, no, chronic Lyme doesn't exist. So that began my 20-plus year journey of trying to understand this. That was 2003. I then retired, and coincidentally, she showed up in my own clinic some years later. But when I started to see Lyme patients more regularly after starting a clinic in 2012, an integrative clinic, they would come in with the expectation that they should have antibiotics right away, and I would often oblige them, and became consistently frustrated that only a few of them got better. A large proportion actually had worse symptoms with antibiotics. Of course, Herxheimer reactions we'll talk about, but also they often just didn't get better, or they got better, and then when they stopped the antibiotics, it all came back again. So, like, what are we missing? So that's really the focus of my discussion after lunch. But the reality is, I believe one of the missing links to this is the immunoderangement that you have from having mycotoxicity. And mold is a double-edged sword because it can be an infestation or infection. Many of these folks who have mold in their environment, and frankly, 50% of basements in Ontario have water intrusion, water damage, and mold. And I'll show you tomorrow the genomics that predisposes and predicts that people are going to have problems clearing mold, the infection, and mold mycotoxins. And the mycotoxin, by the way, that you might be aware of from penicillium, black mold, mycophenolic acid. What is mycophenolic acid used for in conventional medicine? Made into two drugs by big pharmaceutical companies. One of them is Cellcept, the other is Mycofort, and they're given to organ transplant recipients to prevent organ rejection. Why? Mycophenolic acid is a profound suppressor of proliferation of B and T lymphocytes. Okay, so people have mold. The spores of mold get into the air. They're aerosolized. They're very small, less than 2 nanometers. Even if you have a forced air, people say, well, I have mold in my basement, but I never go down there. Doesn't matter. You're getting these spores pretty much spewed through your house, through your forced air furnace. Oh, but I have a filter on my furnace. Yeah, those filters are pretty much useless against these very small mold spores. And the mycotoxins are even smaller, and they're chemicals that can also be aerosolized. So you're getting both a mold exposure, which resides in your sinuses, airways, and gut, plus you're getting the chemical exposure. And that would be fine, because then I hear, well, why am I sick, but my husband and 2 children are fine? Well, I'll show you the genomics that predict that. Nevertheless, you can pick out these people that might have, as part of their MSIDS package, mold by symptoms. Allergy, and of course, even conventional allergists and respirologists are cognizant of mold as a cause of symptoms of allergy. And you can have things like aspergillosis in your lungs, and that shows up on CT scans occasionally, and respirologists get involved with that. But we're talking about different kinds of presentation. Classically, the respiratory symptoms that I identify for mold are sinus, chronic recurring sinusitis. They may have some improvement with steroid and other nasal sprays, but that doesn't eradicate the problem. What they actually need are nasal sprays that contain itraconazole or amphotericin. They may have primary respiratory symptoms, asthma, and they often will have gut symptoms because of mold that are in the intestine. Non-seasonal congestion, so if they're just really chronically congested with postnasal drip, think of mold there. And of course, these mycotoxins can cause very specific kinds of symptoms as well. Fatigue, brain fog, especially word-finding problems, electric shock sensations in the body. This is often not Lyme, this is mold. We heard about anaplasmosis and ehrlichiosis, which are in the rickettsiosis family. They're very sensitive still to antibiotic doxycycline. We don't think that they are contributing much to chronic illness. Other rickettsioses, I order from public health a whole long litany of serology, not just Lyme, and one that commonly comes positive is Rocky Mountain spotted fever. It's not always clear whether it's actually RMSF or if it's Q fever, Murine typhus, and cross-reactivity, but we see a lot of that in our clinic. I've had only a couple seropositives for Powassan virus. I think it's quite a serious virus to get. It has high mortality in those, especially with immunodeficiency as a substrate. Not sure that it's a contributor to chronic symptoms, and tularemia can possibly contribute to that. I could go on for a very long time, but lunch is waiting, and I think we can take a few questions and then get to the food.